But thank you all for attending this evening and for the opportunity to talk to you today. So this is I'm going to talk to you for about the next 20-30 minutes or so, talking to you about the research that we did evaluating the impact of and the implementation of opt-out when it came in England way back in 2020. My name is, as I said, Dr. Leah Mclaughlin. I'm a healthcare scientist from Bangor University, and I also worked on the opt-out implementation in Wales when it came in. But this was a partnership with colleagues from the London School of Hygiene and Tropical Medicine, Peer Unit, ICNARC, and funded by the NIHR. And I've kind of called this title, it might give you a clue as to what's about to come, implementing a values-driven policy in what I can say maybe is a very complex system. So what happened when the soft opt-out system of organ donation was implemented in England? And this is just our funding statement before we get going. Yes, and please do put stuff in the chat. As I said, I can't see you, and I know this has been recorded, so if anyone has got any more questions or information otherwise. So often with these things, we assume a sort of a level of expertise and knowledge, but I try and sort of give a bit of context when I do this presentation and research, knowing that not everyone was either around or can even remember what was happening back in May 2020 or just before then. So as we all know, we've been through a hell of a time with COVID and other things, and we're still sort of reorientating ourselves for various reasons. But just a bit of background. Following Wales, who implemented opt-out back in December 2015, England implemented a soft opt-out system of consent to organ donation. The legislation was passed pre-COVID back in 2019 and was implemented as planned in May 2020. But from the outset, goals certainly appeared very high from what was coming out of Parliament and legislators. So common media soundbites included there was going to be an additional 700 transplants each year. All adults are considered donors now unless they explicitly state otherwise. And this is an important step forward in making organ donation easier and more available to those who need it, and could help save hundreds of lives every year. And this was going to be a significant step towards helping the 5,200 people in England on the wait list. So with all of those sound bites, I think you can get a flavour of what sort of people were thinking from Parliament and legislators that this was actually going to do when it came in. And just a little bit more context around this. The idea behind this was that, as I sort of mentioned before, this was going to reduce what I call the barriers to deceased organ donation. And one of the key mechanisms of doing that back in the day was this idea that they were going to remove the burden of decision making from families by actually giving decisions about organ donation to you and I to make while we are alive. So essentially, the key change within the legislation, families are essential to the organ donation process, but they are no longer the decision makers. Okay, organ donation decisions are now ours to make, and families are now required to provide information about the medical and social history of organ donation. However, they are also needed to establish in our current system if deemed consent can or can't be applied, i.e. that the deceased has not opted out or told the family that he or she did not wish to donate after death. So maybe again you're getting a bit of a flavour that actually even just to establish the deemed consent, we still have to go through the family. So this is sort of some of the background intentions versus some of what then the process was going to be in terms of deemed consent and what it is, and how it was imagined to work in terms of legislation. So our task was to evaluate the effects of these changes on the organ donation system and those associated with the Deemed Consent Act 2019, with particular reference to deceased donor consent rates and to explain any changes observed. So we did this through a comprehensive mixed method study. We looked at policy debates leading up to the changes and how it came about. We interviewed and surveyed healthcare professionals. We looked at representative public surveys. We did interviews with the public with a particular focus on ethnic minorities and BAME families, and critically families who were approached, about organ donation after their relative died. We looked at routinely collected donor order data from NHS and NHSBT, and this was all informed by input from a lay and public perspective. So these are some of the key highlight findings that we found, and I'll spend the next 20 minutes or so sort of talking through some of them in a bit more detail. But overall, essentially, we found a tension between what was essentially a values-driven policy and an evidence-based approach in policy making. So essentially, there was this tension between values doubts and whether the law would actually work, and it was simply regarded as the right thing to do. So this sounds like a good idea, let's try it in practice. And evidence kind of got lost by the wayside over the 10 years that implementation took to come about, or to put, for the legislation to be passed, and another 2 years for implementation. We're yet to see any evidence of impact on consent rates to organ donation. That small graph there, the dotted line is implementation of opt-out, and the red line, no surprises, is COVID. And although the COVID pandemic coincides with implementation, it's very unlikely that the implementation of the Act actually caused the decline in consent rates that we're seeing now. There's various complex factors that are happening, but the Act itself isn't actually helping anything in terms of recovery and where we are now. Implementation creates a more complex system. So we have at least 2 consent pathways running side by side. And that's creating quite a confused system in terms of consent and actually processes leading to organ donation, whereas the ambition was to remove complexity and burden. Our professionals still have nothing new to support them in their role. And this is especially when the family says no. So when they don't accept the deemed consent, when they decide that the family or the patient had declared a known decision, and even now when people are on the organ donor register. So we still have nothing new to actually bring the families around. So there's nothing in the Act per se that's actually helping people in their very, very difficult roles who are tasked with approaching acutely bereaved families at the bedside. And for families, the organ donation process is even more complex and convoluted. So it hasn't helped what they're having to negotiate with when organ donation is coming about at the bedside. So those are some high-level findings. I'm going to talk you through them in a bit more detail, so hopefully they make a little bit more sense in terms of the complexity of where we are or should I say, trying to implement an opt-out system in our current opt-in system. So this idea between a values-driven and evidence-based approach in policy making, we actually looked at the parliamentary debates, and they clearly demonstrate a tension between those who argued, as I said, it was the right thing to do, and those who argued that it was no real evidence it would work. It was very clear the debates had misinformation about how, where, and when the legislation was intended to work. We also found very low levels of understanding about what deceased organ donation is and what it looks like in the UK context, i.e. sudden traumatic death, dying in intensive care, various pathways to organ donation. None of that was there. We also found a predominantly values-driven approach in the media. So, for example, campaigns predominantly featured children, and children are excluded from the Act, and their organs are predominantly size matched. So increasing the number of organs available for adults wouldn't actually help this population. So, as I said, the values were trumping evidence as it came about. And our follow-up engagement with legislators, they felt the spirit of the Act, as I said, that I started this presentation, this idea that everything will become easier. We're all potential donors now. It's very straightforward for us now to declare our decisions, that had all become lost in implementation. So expectations versus reality. This is the story of this whole project, really. Implementation has created a more complex system. So our assumption was essentially that the opt-out system would replace the opt-in system for people who meet specific eligibility criteria. The reality that, this is an old slide now, I need to update it, but it's not just two systems, there's multiple consent processes and pathways running side by side and overlapping, even at an individual deceased patient level. The reality is we're able to do a lot. Science has advanced. There's amazing things that we can do in terms of organ donation and transplant, and we have an awful lot of legislations and processes now that are overlapping and causing an awful lot of confusion. So again, expectation versus reality. The hard truth is we've tried to implement an opt-out system, and so far our attempts have been unsuccessful. We're not actually able to do it in our current system of organ donation. And our specialist nurses, who are so critical in providing support, information, coordinating retrievals and everything that they have to do, as the key mechanism to link the various people, systems and processes that need to happen between deceased organ donation and transplant. They're regularly needing to switch between all these different systems when working in practice. And depending on the deceased person, this can be very challenging, as the approach to each is very different. So those of us who are not as familiar for deceased organ donation to happen, I mentioned it earlier, it's incredibly challenging cases. They are always sudden death. They can often be violent, so car crashes, suicide. There's an awful lot of things that happen in terms of the bereavement and the stages leading up to the donation that make their jobs very difficult. And the Act hasn't actually given our nurses anything new to better support them in their role. So moving on to a bit more on the professional perspectives, they continuously reflected similar values versus evidence tension. So just a quick quote here: on a societal level, yeah, ethically, morally, etc., of course, this is the right thing to do. But if you're asking what difference it will make, none. And as I said, specialist nurses, specifically those tasked with seeking consent, they've nothing new to support them in their role, especially when families say no. And I'll come on to the reasons why families are declining organ donation in a minute, but the very dense text beside me here is just an example. I don't know if you can see it if I hover my cursor, but it's just to highlight that the Deemed Consent Act has been implemented into all of these different acts, legislations, processes, laws, codes of practice, etc., etc. So it hasn't overtaken anything. We've had to try to find a way to implement this alongside an enormous amount of other sorts of legislation, and it has just created a more confused system. And in a way, it's actually diminished confidence in our nurses and our approaches and what we're trying to do. And that wasn't, again, the intention of the Act. Everything should have got easier rather than sort of more complicated. So it's been very difficult. And our nurses are really stuck in a sense, because they're trying to embed a changed culture of organ donation. But at the same time, they're trying to making the Act work in a way that is tolerable to the different stakeholders and to avoid the potential risks in the organ donation system. So, for example, if families' wishes were seen to be overridden or the NHS perceived to be similarly taking organs. So this is why we had the soft opt-out system in the way that we had it. But the irony is it's the softness of it that's causing quite the problems that we're sort of seeing now. And there's a huge tension between trying to make these background processes work alongside providing the best care for acutely bereaved families. And this is nothing new, by the way. This is what organ donation has always been. Families are acutely bereaved. They're in the early stages of crisis. They really don't know what's going on. So hopefully this has given a bit of a sense of to the difficulties that our healthcare professionals are still facing at the bedside, and why the Act isn't really working as intended or imagined. I'm going to switch tact and talk to you a little bit more about the public. So this is the general public. And it's a strange one, really, in that changing the law has a little impact on the general public's overall support for organ donation, which has remained absolutely high and stable, 80+%. And nor does it have appeared to influence people's willingness to become deceased organ donors. But importantly, that stat is lower than general support for organ donation and your willingness to become a deceased organ donation. So willingness to become a deceased organ donor is about 56%, but there's considerable variation across the demographics and what people wish to donate. Just to highlight, in ethnic minorities, and I'm going to use that in brackets, this is defined in this data set as all non-white donors. So apologies for the crude dichotomy, but it's all that it allowed us to do. Ethnic minority support and willingness to donate remains much lower, so it's less than 20% than the white population, in spite of their proportionality greater need for organ donation. So despite the additional need, the general public in ethnic minorities aren't any more willing to donate their organs, and the Act has had no impact on any of these at all. When we did our qualitative research alongside this overall general data, we found very, very low levels of understanding of deceased organ donation and how it comes about in ethnic minorities. So generally, people are very unaware of what death leading to organ donation looks like. But for ethnic minorities, it's much lower. And although many had experience of donating or receiving, so for example, breast milk, blood, or knew somebody who received a transplant, as I said, many people's understanding of deceased organ donation and what it looks like and how it happens was especially low. And their initial impressions were often linked to highly controversial media headlines unrelated to organ donation. So we have, Nike sues Satan shoes with human blood. We have human skin handbags being produced. So these are the kind of images that people from ethnic minorities in the general public are actually conjuring up. So we're literally going to skinning alive, the depths of hell with Satan. So it is a very, very different initial perspective of what organ donation looks like compared to what we routinely are used to in the system about organ donation and what it is and the good that it can bring about. So awareness of the law change. Awareness of the law change was actually pretty high considering the context it was introduced, but again, lower in ethnic minorities. But the level awareness of general organ donation publicity was low and unstable over the surveys. And that sort of decreased. So the awareness of general organ donation publicity started to decrease as we saw it. And that's probably unsurprising because of COVID. But also there wasn't a lot of publicity around organ donation at the time per se. It was more around legislation and decision making, which got lost in terms of the messages and what it was trying to do. People, in addition, again, with the qualitative work we did, people were very often unaware and shocked by the stark inequalities around the organ donation system in general. And they frequently wanted more awareness of the impact of organ donation on them and their communities. So, you have an example here. It's our people. This was a Black woman. It's our people that are dying. I didn't know that. And this is the message that really needed to be out there. So they weren't aware of the acute impact and the disproportionate impact on them and their communities. The other key issue in terms of the law change, it was really exacerbated by frustrations and inconsistency of the lack of consensus of organ donation on the part of positions in leadership, particularly of the Muslim faith, so imams and community leaders, many whom felt people should have a more active role in addressing these inequalities. So it was common for people from minority and faith backgrounds to feel frustrated that their leaders and people in positions of authority did not agree or have consensus on organ donation. So this was felt to be an ongoing issue that had yet to be resolved, and they weren't getting any further with it. And misunderstandings of the legislation and what it was intended to do were very common. So people thought it had changed and then been modified to include families in decisions. In some cases, misunderstandings of the legislation and what it's intended to do were a factor in people opting out of organ donation. And even people in roles promoting organ donation and even commissioned to promote organ donation within their communities, they felt ill-equipped to answer more detailed questions about organ donation and also how, where, and when the legislation was intended to work. So it came across as generally very confused and not really giving them anything to do or to support them to do to address these issues. So decision making. As I said, the idea behind this was to give decisions to organ donation about you and I to make while we're alive. That didn't easily translate to people in certain communities and particularly ethnic minorities. So where decisions are made together as a family, and sharing their organ donation for some people is actually perceived as a very difficult conversation to have. And it was common for particularly younger and family members necessarily not in a position of power, so women, younger siblings, to delay or put off registering or talking about it with family. And as I said, the changes that the laws brought about didn't easily translate into families where decisions are shared or delegated in a hierarchy. And some people sharing decisions can find it, for example, younger people or second or third siblings or women, as I said, they can find sharing their organ donation decision more difficult. And sadly, further contexts of uncertainty and mistrust were potentially created by the extraordinary events taking place during the pandemic. So, for example, COVID-19, the murder of George Floyd, and vaccine hesitancy. But importantly, we did observe harmful targeted campaigns, which rapidly and easily spread due to social media and people's use of WhatsApp to communicate with their families overseas. And this tended to encourage people to opt out of organ donation and had factually incorrect information underpinning all of that. So we're now in a position where we have a disproportionate amount of people who've opted out from ethnic minorities, but we also know that they haven't necessarily made their decision based on what the Act assumed they would do, which is to make their personal decision based on factually correct information, and have that decision upheld. So it has created an awful lot of confusion around this from the public, with a particular focus on ethnic minorities. So moving on to our donor families or potential donor families. We interviewed 103 participants representing 83 potential organ donor cases. And the biggest, well, the overall biggest finding that with this work is that we had, so 37% of these cases, we saw donation was fully supported. And in 13% the families declined completely. But the biggest finding is that half of the family members, they supported the retrieval of some organs, tissues and procedures, but not others. So the families are still picking and choosing what they want to donate or not based on their own level of comfort and what's presented to them at the bedside at the time. So there's no such thing as a yes or no in organ donation. It's actually families are frequently saying yes and no. And they're doing that because they can. We present those options and choices to them at the bedside. And we also looked a little bit more, I was asked to do this at DBD and DCD cases for the families as well. So the reasons, in summary, why the law was not working as intended for families was for the following reasons. So families didn't understand their role. There was no communications that helped them understand that in the media campaigns or anything else leading up to that. They still see themselves as the moral custodians of their relative who died, and the body and the organs and what happens to them. We have not been able to remove that at all from these conversations, despite of our best intentions to try and alleviate some of the burdens for families. Families didn't always agree with the principle of deemed consent, i.e., that we're presumed organ donors now. They want a more active, registered decision. They didn't always support the deceased express decision. So whether they were on the organ donor register, they felt it was fake, it was outdated, they didn't know what they were doing, it was a mistake. Whether they'd heard other family members talking about it or not, there was disagreements, there was arguments, they got it wrong, they hadn't heard it right, there was misinformation. So even when we have express decisions, families are finding ways to contradict that and to put what they think they know about the family into the conversation. As I said, deceased organ donation was perceived as to the families as contrary to their own interests. So it's not what they would have wanted. If they saw what this was doing to me, then they would not agree to the organ donation. And that's very difficult to come back from because, of course, the family member has died at that time. So there's no other reasoning or rationale for anyone else to sort of cling on to. One of the main reasons that we see in all of this is that families questioned if their relative wanted surgery, even if this would have the potential to save other lives. So it's not the donation per se and the possibility of saving lives. It's what's happening under the lights. So being had to bix, pulled apart, splayed out under the lights. It's the actual surgical procedures that the families are actually struggling with and why they're declining the organ donation. They find the pathways leading to donation exhausting and confusing. As I said before, the consent and the documents is very long. It's a very long process what they're going through. And sometimes they can receive mixed messages when transitioning from end of life to organ donation discussions. So they might have a conversation, well, they're dead now, let's stop their suffering, let's move on. And then there's an organ donation potential brought in on top of that. And the family then is preoccupied with this idea of the family being suffering and it's taking too long. So those messages are quite difficult for the family to really understand what's happening. And as I talked about, the consent process is protracted and complex. So for our families, they're in awe of what can be donated and what can be of benefits to patients. But as I said, they've no idea which organs and tissues come under the Act. Our nurses are critical in walking family members and supporting them through a very confusing process. But as I've been saying before, we do have a very confused consent system now and things are working, overlapping side by side. And the families have no idea when or what this happens. It's all one thing, and it doesn't really matter whether it's an opt-in and an expressed or a deemed consent. The process is the same for every family at the bedside. And as I said, the specialist nurses are critical in turning this lengthy process into a positive experience. They regularly describe the consent process as an interview, and they retain little memory of detailed knowledge of what they were being asked at the bedside anyway. So moving on a little bit to why families say no in complex cases. It's a cumulative process. It's never one thing. So a few things, health system issues, the organ donation question can come as a complete shock for families. And if families feel that, they can have a sudden switch from care and support into they want something. Families will often ask for more information from various sources and get mixed information, as I said. Perceived delays with no guarantees of an outcome. So, for example, DCD means some family members might feel a right to step in and say no if they see other family members in increasing distress. We still have no ways of establishing what is a verbal opt-out with certainty. And this is because family members who know the person that they lived with for the last 30 years or even longer, they are frequently piecing together events, scenarios and conversations, often over a long time, into a narrative they believe their relative did not want to be an organ donor. But it's actually nothing got to do with organ donation. As I said, it could be views on hospitals, surgery, death, burials and rituals. And these narratives often catch fire, and we see one family member going out of their way potentially to stop or convince the rest of the families. And it's not because they're trying to stop the organ donation. It's because at this point they actually genuinely believe they're acting in the best interest of the person. So they will become warrior family members. They are defending what they believe to be the right situation. And it's nothing got to do with even their beliefs on organ donation. They're protecting what they see as an incorrect or wrong decision and stopping them from further harm. Going back to the Act, it's actually very rare for families to have absolutely no idea what their relative wanted. And according to the way we're currently working, this is only the situation where deemed consent can be applied. When they do have no idea, however, they find this incredibly challenging, and they're frequently making decisions based on the organ donation retrieval processes, as I said, and if their relative would have wanted the surgery. So, for example, splayed out, people watching under the lights, messed around with, hacked to bits. So they're not recognizing that the person is dead. They're imbuing them with views, values, and preferences as if the person was still alive. And it's that information, so not if the person hypothetically or in principle wanted to save lives, that the families continuously wrestle with in their decision making. And that's because we're always going to be speaking to the acutely bereaved. As I started with, many things are discussed in the days leading up to withdrawal and donation. Cases are complex, highly individual, often especially traumatic and violent, young people in suicide. And we often see cases where families might initially say yes, but then they will turn as they see a situation unravel. For example, an overwhelming desire to keep the person close. And just a few more slides just highlighting this in a bit more detail. There is a difference of being told that the person has died, DCD, versus being told they will not survive. So DCD is associated with more confused and mixed messages, overwhelming and difficult decisions, increased family burden, common instances of families initially saying yes, but then withdrawing from the process completely, increased perceptions of harms, increased perceptions of delays, progressing to funeral, for example, and higher uncertainty. So, for example, on a DCD, there's no guarantees of a successful organ donation retrieval. So when that's presented to families, you can start to see how things can actually quite quickly and understandably start to fall apart. This continued, and as I said before, this is a family affair. So often if families see other family members in increasingly distressed, often in confirmation with the aforementioned, it tend to lead to a rejection of the benefit to transplant recipients and a shift towards the benefit of what is best for the family. So they don't think that they're doing anything wrong. They're just trying to weigh up what the pros and cons and the benefits for them and their family are at the time and at the bedside. And as you're probably seeing now, the legislation is not helping any of those things. We are moving further and further away from an ideal policy into the realities of what organ donation is and what it looks like. More reality. Families equally wrestle with DBD, which can quickly become associated with an unnatural death. So, for example, hooked to a machine, heart still beating, dying too quickly, not at peace or undignified, and especially without the family present. So I'll just let you read one or two of those while I have a quick sip of my coffee. Talking for over half an hour solid. So letting the person go. This is the reality of what organ donation is and what it looks like. And as much as we'd like to tell ourselves, and we do tell ourselves and we promote the good and the benefit of organ donation, for the family, organ donation is absolutely horrible. And it's a horrible situation to be in. And they need an awful lot of support, an awful lot to actually get through this, because it's not easy at all. In all cases, for parents losing their adult child, but this didn't include children under 18s, but parents in particular, they struggle with the latter stages of donation, which involves letting their relative literally go for organ retrieval via DCD or DBD. It's it's a very, very, very difficult time for families to get their head around with. Families start to overlay the original decision, however it was made, whether they were on the organ donor register, whether it was expressed or deemed as I said, into a narrative of what the deceased would have wanted for the family in their situation and what they were going through. And again, this narrative kind of prioritized the family over the benefits of deceased organ donation. So we're moving into a little bit of the key points now and recommendations. So some more nuanced ones. DBD generally offers families more certainty and quicker closure, while DCD is associated with prolonged emotional burden and logistic delays. Overall, families can quickly lose sight of the end goal to save lives and favour what they perceive to be a better outcome for them. The soft opt-out system is not helping any of these emotional procedures. So some of the key recommendations include simplifying consent processes, improving public understandings of the law. Media campaigns need to clarify the role of the family, as well as seek to demystify some of the processes leading to organ donation, give greater legal weight to decisions of you and I when we've made them, and more resources for intensive care are also absolutely critical. So essentially implementing a soft opt-out consent system into a previously well-established opt-in consent system has been challenging. There's actually little published literature describing how best to implement such a change, but the values-based intentions of the Act to give organ donation decisions to individuals to make while they're alive have not been easy to implement at all by staff and systems dealing with the acutely bereaved. And maybe if there was more evidence of efficacy and effect, rather than being simply a matter of principle, the Act might be given higher priority for the NHS. But nonetheless, the pathway to organ donation is very complex. There remain service constraints and logistics to organ donation which influence families' experiences and behaviours. The Act has had no impact on these. And health policies are enacted through their implementation, not through simply changing the law. And legislators do need to take more account of the constraints inherent in the systems through which the laws are to be realised in practice. There remains a legacy of informed consent, which has proved very difficult, if not impossible, to fully switch in practice. No one is able to presume anything in our current system. We did a little bit of work globally looking at what the impact of this in England tells us about the effectiveness of deemed consent systems for deceased organ donation globally. And I won't spend time on this, but essentially laws alone make little difference to consent rates. And we see across countries and policies that legislators tend to overvalue the impact of changing the default of citizens to one that presumes consent, and they underestimate the de facto power given to families. And the human complexity of organ donation means implementation in practice rarely corresponds with any policy intentions. These are just some of the networks and patient and public networks that we've had supporting us throughout the study, and we really couldn't have done this without all of these people involved in it. So a massive thank you. This is the team, mostly NHS and NHSBT colleagues that have been supporting us throughout the project. It's all completed now, so you can read on. Some is quite long and dense, but there are some nice sort of summaries in the conversation and through expert opinion pieces. And I'm delighted to say I'm not able to share it today, but we have done an update to the Health Talk Deceased Organ Donation module. So we're hoping to be able to provide some updates to the public to address some of the research findings, to try to clarify the role of the law change, to hear a little bit more from real life family stories, as well as our specialist nurses who are talking about organ donation, to hopefully act as a resource to address some of the problems and benefits and the good things that organ donation can do, but also the intentions of what the legislation was trying to do.